Hello everyone, this is Dr. Sangeeta Chaudhary again and I welcome everyone to my lecture class. In my today's class, I am going to discuss about hyponatremia, which is a very important topic and it is also considered as a medical emergency. So we need to know about hyponatremia. In today's class, I will talk about the causes of hyponatremia, approach to a patient of hyponatremia, how do we diagnose a case and how do we treat a case of hyponatremia. So what actually hyponatremia is? As per the definition, hyponatremia means when the serum sodium concentration falls below 135 milliequivalent per liter. The normal value of serum sodium is in between 135 to 145 milliequivalent per liter. And when it goes below 135, we call it as hyponatremia. Now suppose we have got a patient of hyponatremia. So our first job will be to differentiate if it is a true hyponatremia or it is a pseudo hyponatremia. Pseudo hyponatremia is also known as isotonic hyponatremia. In cases like hyperlipidemia and paraproteinemias, we may get pseudo hyponatremia. Why pseudo? Because the low serum sodium is not because of any pathology, but it is rather an erroneous lab value, because hyperlipidemia and paraproteinemia causes increase in the non-aqueous portion of the plasma, which ultimately results in a erroneous detection of low serum sodium level. That is why it is known as pseudo hyponatremia, not a true hyponatremia. If we talk about the symptoms of hyponatremia, the symptoms of hyponatremia are mainly neurological. The patient may present with mild symptoms such as nausea, headache or malaise, body ache, or the patient may present with severe symptoms like reduced level of consciousness, severe headache, patient may present with seizure, there may be coma, and patient even may die due to severe hyponatremia. If we talk about investigating a case of hyponatremia, there are three very important things which we need to know so that we can classify hyponatremia and we can treat hyponatremia depending on the classification and the causes of hyponatremia. So these three investigations are plasma osmolality, urine osmolality and urinary sodium. Okay, and the importance of these things I am going to discuss next. If we talk about the diagnostic approach of a patient of hyponatremia, we can discuss the following flowchart. And in this flowchart, I am going to discuss about the various investigations we do for hyponatremia and the classification of hyponatremia depending on the investigations, as well as the causes of hyponatremia. First of all, we need to do a plasma osmolality. If we see that plasma osmolality is more than 290 milliosmol per liter, then it is known as hypertonic hyponatremia. And the causes of hypertonic hyponatremia can be increase in blood glucose level or use of mannitol. It has been seen that per 100 milligram per deciliter increase of blood glucose results in lowering of serum sodium by 1.6 milliequivalent per liter. Okay, per 100 milligram increase in blood glucose results in lowering of serum sodium by 1.6 milliequivalent per liter when the glucose level is above 100. Okay, but if the blood glucose level is above 400 already, then per 100 milligram increase above 400 level will result in reduction of serum sodium by 2.4 milliequivalent per liter. Anyway, so this is about hypertonic hyponatremia. If plasma osmolality is in between 275 to 290, that is known as isotonic hyponatremia. And isotonic hyponatremia, as we have already discussed, which is also known as pseudo hyponatremia, it can be because of hyperlipidemia and hyperproteinemia or paraproteinemias. Now, if the plasma osmolality is less than 275 milliosmol per liter, then it is known as hypotonic hyponatremia. Okay, so in hypotonic hyponatremia, here comes the role of urine osmolality. Once we know that the plasma osmolality is less than 275 and it is a case of hypotonic hyponatremia, we will go ahead with a urine osmolality. If the urine osmolality is less than 100 milliosmol per liter, then we can think of primary polydipsia and beer potomania. If it is more than 100, okay, then here comes the role of extracellular fluid volume. Once the urine osmolality is more than 100, we will look for the extracellular fluid volume. If extracellular fluid volume is low, which is known as hypovolemia, if it is there, then it will be a case of hypovolemic hyponatremia. Now here comes the role of urine sodium. In the beginning, I talked that there are three main investigations which we should be doing to classify the causes of hyponatremia. One is plasma osmolality, one is urine osmolality, and the other one is urinary sodium. So we have seen the role of plasma osmolality in classifying hyponatremia as hypertonic, isotonic, and hypotonic hyponatremia. Then if it is hypotonic hyponatremia, we will go and look for urine osmolality. If urine osmolality is more than 100, we will look for extracellular fluid volume. If extracellular fluid volume is less, that means if there is hypovolemia, then it will be a case of hypovolemic hyponatremia. And here comes the role of urine sodium. If urine sodium is more than 20, okay, if it is more than 20 milliequivalent, then it is because of renal loss. That means sodium loss is because of some renal mechanism. So it may be due to use of diuretics, it may be due to osmosis, osmotic diuresis, it may be due to cerebral salt wasting syndrome, it may be due to bicarbonaturia, or may be due to ketonuria. Bicarbonaturia with renal tubular acidosis. Okay, so these are the few causes of renal loss of sodium in case of hypovolemic hyponatremia. If it is if urinary sodium is less than 20, that means the loss of sodium is extra renal. It can be GI loss or it can be insensible loss. Okay, so it can be due to diarrhea, it can be due to vomiting, it can be due to third space loss, burn, pancreatitis, or maybe due to loss through the sweat. Okay, this is about hypovolemic hyponatremia. Now, if the extracellular fluid volume is normal, that means if there is euvolemia, then there are few causes of hyponatremia. It can be due to cortisol deficiency, it can be due to hypothyroidism, it can be due to stress, or it can be due to SIADH, that is syndrome of inappropriate antidiuretic hormone secretion. This is one of the very important and common cause of euvolemic hyponatremia. Now, if extracellular fluid volume is more, that means if there is visible edema and ascites, then it is known as hypervolemic hyponatremia. In that case, again, we are going to look for urinary sodium. Again, if urinary sodium is more than 20, it is because of renal loss. It may be due to acute kidney injury or chronic kidney disease. And if urinary sodium is less than 20, it is maybe because of heart failure or liver cirrhosis or nephrotic syndrome. So this is about hypervolemic hyponatremia. So this is all about the diagnostic approach of a patient of hyponatremia. Again, I'll say first we will look for plasma osmolality. It can be if it is hypertonic more than 290, it is hypertonic hyponatremia. In between 275 to 290, it is isotonic hyponatremia. Less than 275, it is hypotonic hyponatremia. Hypertonic hyponatremia may be due to increase in blood glucose, then use of mannitol. Isotonic I have already discussed, due to hyperlipidemia or hyperproteinemia. If it is hypotonic, then we are going to look for urine osmolality. If urine osmolality more than 100, we will look for the extracellular fluid volume, and then again we will subclassify into hypovolemic hyponatremia, euvolemic hyponatremia, hypervolemic hyponatremia. And after this classification, we will look for urine sodium in all the cases, and we will classify if the loss of sodium is due to renal causes or it may be due to extra renal cause. So this was about the diagnostic approach. Now, if we talk about the treatment of hyponatremia, there are very important things which we should really be remembered in case of treating a case of hyponatremia. The rate of correction, which is very, very important, which I am going to come later on. Then appropriate intervention is needed. The patient might require only restriction of fluid, or the patient may require some pharmacological treatment. Okay, this will depend on the patient's condition and presentation. And treatment of underlying disease is very important. Most of the time, treating underlying disease will resolve the hyponatremia. Now, if we talk about specifically hypovolemic hyponatremia, then the treatment of choice will be administration of isotonic saline. Administration of isotonic saline will result in increase in intravascular volume, okay, and ultimately it will lead to water diuresis, leading to correction of hyponatremia. If it is a case of hypervolemic hyponatremia, as we have seen, it may be due to AKI or CKD, or it may be due to heart failure, liver cirrhosis, nephrotic syndrome. So in those cases, fluid restriction is important. Then we can use loop diuretics, and treatment of underlying cause is very, very important. If we talk about the euvolemic hyponatremia, then water restriction is very important. Sometimes the patient will improve only with water restriction, and of course treatment of underlying cause is very, very important. Now, when we talk about the water restriction, how much should be the level of restriction of water? For that, this following formula can guide us. Okay, we need to see the ratio of urine sodium plus potassium and plasma sodium. If the ratio is more than 1, then the restriction of fluid will be less than 500 ml per day. If it is 1, okay, then it will be restriction will be 500 to 700 ml per day. If it is less than 1, then the fluid restriction may be up to 1000 ml or 1 liter per day. Now, for euvolemic, first we will think of water restriction. We will treat the underlying cause. Then we can use loop diuretics plus oral salt tablet in cases of SIADH. And demiclocycline is the drug of choice in case of SIADH, that is syndrome of inappropriate antidiuretic hormone secretion, because it will antagonize the antidiuretic hormone function. And there are drugs approved by FDA, that is tolvaptan and conivaptan. They are vasopressin receptor antagonist. Okay, so they promote water diuresis, so they can also be used. Tolvaptan is a V2 receptor antagonist. Conivaptan is V2 and V1A receptor antagonist. Conivaptan is available in IV formulation, and tolvaptan is available in oral formulation, which we usually use. Tolvaptan can be used for up to 1 to 2 months. Conivaptan should not be used for more than few days, maybe 4 or 5 days. Now, very importantly, if we talk about the rate of correction, okay, it is very important. Because if we overcorrect, if we do overcorrection of hyponatremia, or if we do very fast correction of hyponatremia, there will be chances of ODS, which is known as osmotic demyelination syndrome, okay, or central pontine myelinosis. Okay, and in these cases the patient will present with quadriparesis. The patient may present with pseudobulbar palsy, then swallowing difficulty, all these things. The patient may present with coma also. So we should be very careful in correcting the hyponatremia. For the correction rate of correction of hyponatremia, we need to know if it is an acute hyponatremia or if it is a chronic hyponatremia. If it is acute hyponatremia, means the hyponatremia has been lasting for less than 48 hours, or the onset of hyponatremia is for less than 48 hours, then it is acute hyponatremia. And in that case, if the patient is severely symptomatic, we need to correct the serum sodium level, and in that case the rate of correction will be 1 to 2 milliequivalent per liter per hour for 3 to 4 hours. Okay, this is for acute hyponatremia. We are going to do a rapid correction for the first 3 to 4 hours. That is 1 to 2 milliequivalent per liter per hour we are going to correct for the first 3 to 4 hours, and by this time, after this much of correction, the symptoms usually gets resolved, and then we can taper off the rate of correction of sodium, and we can correct up to 12 milliequivalent over 24 hours. If you talk about chronic hyponatremia, that means the hyponatremia has lasted for more than 48 hours. That means the onset of hyponatremia is for more than 48 hours of duration. Then in that case, the correction should be slow. It is not like the correction of acute hyponatremia. In that case, for the first 24 hours, the correction should be up to 8 to 10 milliequivalent per liter, not more than that. So 8 to 10 milliequivalent per liter over first 24 hours. Okay, and it should not exceed more than 80 milliequivalent over first 48 hours. Okay, so this is about the rate of correction which we should definitely remember while treating or correcting the serum sodium level in a patient of hyponatremia. Now, how we correct hyponatremia? For this I'm going to give an example. First, let's see the formula which is very helpful in correction of hyponatremia. In correction of hyponatremia, and to identify the rate of correction, we can use the formula. It depends on the infusate we are using to correct the hyponatremia. So the change in serum sodium, the change in serum sodium by 1 liter of the infusate, that is delta sodium, we can find it out by the formula, that is sodium in infusate minus serum sodium of the patient divided by total body water plus 1. Again I am saying the change in serum sodium by 1 liter of the infusate will be sodium in infusate minus sodium of the patient divided by total body water plus 1. If I give an example, it will be very much clear to you. Suppose an 80 kg female has come to us with a serum sodium level of 108 and the lady is having severe symptoms. Only if the patient is presenting with severe symptomatic hyponatremia, then only you are going to do rapid correction of hyponatremia. So in that case, we better use a 3% of sodium chloride solution. 3% of sodium chloride solution contains 513 milliequivalent of sodium per liter. Okay, so now if we are using 3% of sodium chloride solution, 1 liter of 3% sodium chloride solution, now the change of serum sodium will be 513, that is sodium in the infusate minus patient's sodium, that is 108, divided by total body water. Now patient's weight was 80 kg and since she is a female, so total body water will be 50% of the body weight. So 80 multiplied by 0.5 plus 1. So the ultimate result is 10. So 1 liter of 3% sodium chloride solution will increase the serum sodium level by 10 milliequivalent per liter. Okay, this much we are clear. So if it increases by 10 milliequivalent per liter, and for this particular lady, since she is presenting with acute hyponatremia with severe symptoms, we need to give a correction of 1 to 2 milliequivalent per liter per hour for first 3 to 4 hours, as I have already mentioned before. Okay, so we can use 100 to 200 ml per hour until symptoms improve, or for first 3 to 4 hours. Now 100 to 200 ml per hour, giving 100 to 200 ml per hour means correcting 1 to 2 milliequivalent per hour until symptoms improve, or for first 3 to 4 hours we can correct. But we should remember that we should not be using more than 1 liter of 3% NaCl solution over 24 hours, because otherwise it will be a overcorrection, as we already know that 1 liter of fluid will correct 10 milliequivalent per liter. Okay, so since we don't want to overcorrect, so we can limit the use of 3% NaCl 1 liter over 24-hour period for this particular case. Okay, so this is how from this formula we can easily calculate the change in serum sodium by using a particular infusate, and we can really calculate the rate of infusion of the infusate, may it be 3% sodium chloride or any other hypertonic solution. Okay, so this is all about hyponatremia which I wanted to discuss with you. I hope this class was helpful. We really need to know about hyponatremia because in day-to-day practice we really see many cases of hyponatremia, and since it is considered a medical emergency, we really need to know the treatment, how we should correct it, what should be the rate of infusion, okay, and what should be the causes, what should be the treatment of underlying diseases. Everything we need to know about hyponatremia. Thank you so much for your patience hearing. Thank you.